Hi everyone, I'm Susan Nancarrow. I'm the Chief Executive Officer of Health Work International, founding chair of AHANA and a director of AHANA. And in the room we've got Andy Richardson, who is the current chair of AHANA, and Megan Kruger, who runs all of our events for us. Thank you very much for joining us. We are recording this. I'll get the conversation started so you can see what we had proposed to talk about. But since it's such a small group, we're really happy to frame this to meet your needs. As I mentioned, it's being recorded. If you don't want to be recorded, then please switch your cameras off, but it'll be on the AHANA website. I'd like to start by acknowledging the traditional owners of the land from which I'm meeting, which is the Bundjalung Nations of the Arakwal people in northern New South Wales, and also pay our respects to elders past and present and emerging. And I also invite you to acknowledge the traditional owners of the land from which you're joining us today. We thought we'd go through three things: the roles and opportunities for allied health assistants in the disability sector, the role of AHANA, and some of the challenges of effectively engaging the allied health assistant workforce. I don't know whether you have some specific issues that you'd like us to talk about. The context for this was the NDIS Task Force on Health Worker Regulation, and the fact that we know that there will be a requirement for probably the disability support workforce to be regulated, and we feel that AHANA presents a ready-made option for your allied health assistant workforce. But, all right. So allied health assistants, as we recognise them with AHANA, are actually allied health assistants have been around for a very long time, as long as the allied health workforce has been around. But I guess the particular components we emphasise with AHANA: interdisciplinary, person-centred care. They can provide services to individuals and groups. But I guess what's particularly important is that they work under the supervision, directly or indirectly, of an allied health professional. So that is, I guess, one of the things that differentiates allied health assistants from disability support workers, but it is also one of the challenges that we're experiencing. So we'll go into that in a little more detail later. Look, I've been giving versions of this presentation for the last 3 years, and each time I do it, I just go to Seek to see what the job advertisement rates are like for the workforce that you're most likely to be employing in the disability sector. This just shows the change in advertisements for speech pathologists. The top one is about this time in 2022, the middle one's about this time last year, and then the bottom one is today. So you can see that the number of advertisements for speech pathologists have gone up by about 1,400. Small workforce, between 10 and 15,000, so that's quite a lot of people. And I'm really giving you these as examples because you will know that there are vacancies in these workforces, but it highlights potentially the ways that we can use allied health assistants. This is the same data, but for occupational therapists. Wasn't a big change last year, but again, they've gone up by well over 1,000 in the past 12 months. And these are job advertisements. So we don't really have good indicators of unmet need or demand, but advertisements on seek.com probably a fairly good indicator. Physiotherapists, again, they've gone up by nearly 1,000 vacancies over the last 12 months. And that's at the same time that we have over 40 degrees now training physiotherapists in Australia. So we know that the supply has increased, but the demand is still never ending. This is the particularly scary one. I don't know how many of you employ social workers, but the number of jobs advertised for social workers in the last 12 months has trebled. So again, they're a self-regulated workforce, but I think AASW has around 20,000 members. We estimate that there are probably twice that many social workers in the country, but we know that the disability support workforce, the disability workforce is mopping them up a lot. The reason for saying that is we know that allied health assistants are an opportunity to meet some of your allied health workforce needs, and they are being underutilised. But in saying that, you can see that job advertisements for allied health assistants have gone up by about 1,300 in the past 2 years. I didn't have 2023 data for them. So basically what we're seeing is just huge unmet need in the workforce, which I'm sure you're familiar with, and some of that is, of course, directly correlated with the growth in the NDIS. So what can allied health assistants do? Look, there are a number of different ways of looking at this, but I've chosen one project that I wanted to talk through because it really shows that we don't necessarily need to have many physios or many speech pathologists. We can really have quite multidisciplinary allied health assistants. So this is really just for illustration. The project's actually 10 years old, and it's draws on a rural and remote generalist allied health project. The issues are similar though, even though it's health and rural and remote. And the problem was that they didn't have enough workers to meet the needs of rural and remote areas. If you've got a population of 2,000, you just can't get the business case to get a full-time physio, full-time OT, any of them individually, let alone a multidisciplinary team. So this project looked at how they could, instead of getting a multidisciplinary team, get multidisciplinary practitioners. They used a workforce re-engineering tool called the Calderdale Framework. And so that looks at two things. One is the needs of the community that you're working with, and the other is that the skills or the competencies that you've got in the workforce. And it starts to break down and look at how you can match those skills and those competencies. I'm not going to go into that in detail, but you'll get an idea when I go through this. So they looked at 6 professions and got them to identify, sorry, that formatting's gone a bit odd, got them to identify the unique tasks that they delivered for the populations that they were working with, including allied health assistants. What was interesting that across the 6 professions, they identified 337 unique tasks, 127 of those professions. One thing that was interesting, and I'm putting this in because it was interesting more than necessarily relevant to this project, but I guess it talks about task transferability. I would have expected that each of the professions would have had more of their own unique tasks, so more jobs that were only physiotherapy, only occupational therapy. But actually what that exercise showed is that I think physiotherapists had the highest proportion of unique tasks at 26%. Occupational therapists, it wasn't surprising, not a huge proportion of unique tasks, but around 20%. And what that tells us is that most of the tasks done by allied health professionals can actually be delivered by more than one professional, which is really quite important when we're in these workforce shortages. I guess what's really important or interesting here is they didn't put those tasks back together under a professional heading. They put them back together under functional competencies. And so a lot of these will be familiar to you as things like activities of daily living, but they were really based on needs of the groups that they were working with. And so the reason, and I realise some of these would be relevant to your NDIS clients, but the reason for putting this here is to really show that the allied health assistant workforce and actually the allied health workforce can be reconstructed to work across a range of different client groups, a range of different competencies, and there are tools out there that can help you redesign that. This was a complex and expensive process to go through, but I think we're getting to the stage where we can design, and maybe you already have an experience of having a multidisciplinary or an interdisciplinary allied health assistant workforce. So this is a really bad slide because I literally cut and pasted it from the report, which was also badly formatted. But what it shows is the actual tasks that were delegated to allied health assistants. And the 2 points I'll make here is, first of all, they found that 147 tasks could have been delegated, but actually fewer than 50 of them were. But again, what's really interesting here is they're not discipline-specific tasks. They are all around functional issues or needs. So we're not seeing little physiotherapists or little occupational therapists. We're seeing bundles of competencies and skills. And I think this is the real opportunity that we have in the allied health assistant workforce. I apologise, the next slide is just as bad, but this shows the actual tasks that were available for delegation. So, we've got a shortage of speech pathologists, so we know swallowing can be delegated. Communication and hearing, developmental and child health, fatigue and sleep, foot care, diet, nutrition, activities of daily living and function. So what we have is a flexible workforce that can be redesigned to meet the needs of your clients and your client groups. I'm going to stop there and just see if anyone's got any questions before I hand over to Andy to talk about the role of AHANA in this space and how AHANA can be used to support you. Yes, Susan.
Can you hear me? Sorry. I was just wondering, Susan, if that report's available. Is it on your website?
It's in the public domain. I'll drop the link into the chat before we finish.
Thank you. That'd be great, because I think some of those things would be really valuable for me to be. I work across all of the community services and all of the health areas. And one of the things that I'm really trying hard to do in New South Wales across our sectors is to actually promote the role of the allied health assistant. And particularly, and I'm interested to see the allied health, professionals in the room is to try and promote how our allied health professional workforce can actually work more effectively with the assistant workforce, because I just find that's really, really difficult. And we've got allied health assisting available as a school-based pathway for year 11 and 12 in New South Wales. And you probably know that part of that qualification has mandatory work placement. I've got to tell you, it is so problematic finding organisations to support that mandatory work placement, and without it, the candidates, then the year 11 and 12 students, cannot get their qualification. And so it is absolutely driving everybody, all the registered training organisations, me, because 9 times out of 10 that email comes into my inbox. You know, it's just creating a huge headache. We've got so many young people who are interested in taking that on and seeing it as a pathway into university and into the professions, and the barrier is at the first hurdle. You know, and it's just a nightmare. Oh, good. Anyway, so soapbox moment, sharing my woes. I didn't mean to put that on you, but those sorts of reports could be really, really valuable for me when I'm actually trying to promote, you know, well, what it is that this allied health assisting workforce can actually, how you can work and how they can support. So thanks for that.
No, that's actually really valuable for us. Do you think the problem is the capacity to supervise the students, or
well, I
just
think
an
that's
unwilling?
yeah, I think that's what that I think that's the barrier that's seen, and I'm not sure how it's being addressed. I must admit that another one of my, you know, burr under the saddlebag moments is trying to get universities to promote during the training actually of how to work with an assisted workforce, because I really feel like the barrier is starting. And I know that we've got an old, you know, like there's obviously older people in the workforce, but if we could actually even just start trickling it out with the new entrants and the new graduates, then it would seem to me that we'd at least be starting. But it's
Really depressing to hear you say that. I mean, I've
oh,
been doing research in this area for 20-something years now, and the problem has been there all that whole time.
it has been there that whole time. And when the qualification was, sorry, tell me to stop talking. But when the qualification was first introduced into the training package, I worked really, really hard with the local area health district in the Riverina and Charles Sturt University. And we got all of the people, all of the allied health professionals, and the first 1.5 days were literally cleaning the blood off the walls from the AHPs, saying, oh my God, we've got to do our masters, and you're telling me that you're going to have a Cert 3 and a Cert 4 coming in and doing our job. And trying to unpack that an allied health assistant role is not taking the role of the allied health professional literally took us to the end of the second day. And then the third day was, well, okay, let's see what we can do about it. You know, and even though, and as Susan, as you said, even though while the qual wasn't there, the allied health assistant was actually working. You know, it was
Exactly. That's right.
just formalizing it through actually
Right.
qualifications and training. But it is one of the most frustrating areas across all of the sectors that, and I work across about 100 industry sectors, and it is one of the most frustrating areas. And I've had more barriers put in place with this particular role than any of the others across all of the community services and health sector, and that's saying something.
Thank you. I hope you feel better now.
No, no, you know, it's another 15 years on, Susan, a bit like you with your 25. But you know, I'm sure that my Chinese drip torture, you know, it's got to pay off sometime. So hopefully, being part of this and hearing this and being able to spread the word, you know, hopefully there'll be a small but significant group who really will bring about change, and that will be fabulous.
Malak or Molly, did you have a question? Okay, Malak, welcome. Matthew, if you have any questions, feel free to drop them in the chat. I might hand over to Andy now to talk about the Allied Health Assistant National Association.
And before I get started,
sorry, Malak. Hi. Oh, sorry, Malak.
No,
sorry.
I was just saying thank you for the welcome. I didn't know if I put my hand up or not, but that was an accident. My bad. So
okay. Welcome. Okay, over to you, Andy. Sorry, I've popped this task force stuff in. Do you want me to talk through that, or did you just want to quickly mention it?
You can really mention this, but I just wanted to reinforce something else to Susan, just so she's aware of as well. I've been doing a lot of collaboration recently with a few of the different university programs, and what a few of them have started to implement is combined health qualification that embeds the AHA qualification as part of the overall degree, so that they're getting slightly more education around the AHA role so they can more appropriately delegate by the time that they graduated, but also that it gives them an avenue to actually start working in the industry while they're still studying. So Swinburne, Charles Sturt were a few of them. Sunshine Coast actually has a specific allied health degree that includes such transitional pathways for their students to be able to use, like a level 1 and a level 2 sports trainer and sports first aid, as well as the allied health assistant qualification before completing the degree itself. So there's avenues for them to be actually step out and work in the industry and then come back. But again, it's finding the placements and giving those initial pathways to come through. But then there's wonderful education and research pieces out. There's a scholar up at CDU up in Northern Territory who did a few wonderful little research projects around the efficiency of the delegation model of the AHA, and that allied health professionals that started as an AHA that went into a role of an allied health professional were of course more efficient in their understanding of the role of the AHA, could consistently delegate more effectively. Therefore, both the AHA and the AHA and the AHP were more consistently working to top of scope, therefore improving efficiency of the service itself, decreased risk of burnout, increased risk of job satisfaction, all the wonderful things that we expect that we're going to hear anyway. But at least there were a few little research projects that were coming into play.
Okay, I've got the right screen on at the moment.
Next one.
So part of the reason for this is that there's just been the new NDIS regulation task force recommendations, and there are 3 recommendations that are relevant to the disability support workforce. And essentially the gist of it is there will be some kind of workforce regulation, and they're proposing this 4 types of registration. This is a little bit complicated because there's also been a Commonwealth review of regulatory complexity. So we expect that these 2 things will happen together. So I guess the points I want to make is we are expecting some kind of regulation requirement for disability support workers. What this looks like, we don't know, but we know that you're going to be looking at, this is provider obligations, but code of conduct. This points out there's going to be a worker registration scheme for all workers. What does worker mean? But the point that we really want to make today is that practitioners who already hold a professional registration can have that registration recognised. And so I guess our proposal is, we know that there are already a number of allied health assistants working in the disability sector. So AHANA provides an opportunity for that workforce to become self-certified through the regulation framework. And the second opportunity is that we know that a lot of disability support workers do work that is like an allied health assistant, and it might be an opportunity for them to basically get a regulation, get registration through a self-certification framework. But Andy's going to talk about what that looks like for AHANA.
Yeah, so some of the main problems that we've identified and we want to try and help with sorting out is, of course, quality insurance for the AHA workforce, the lack of consistency in standards that of course we understand that happens from state to state and of course across all the sectors, lack of clarity and the risks about employing an AHA if you haven't had one before. There is a lot of underlying information you need to investigate in your service itself as to how the delegation model of an AHA would impact how your current service delivery is already running, as well as providing that ongoing education to your client base as to the benefits of working with an AHA instead of the AHP. We also, obviously, we support the AHAs to build up the allied health professional workforce capacity and try and address some of the shortages that we recognise are ongoing. And our goal is to try and make sure that we can offer as much service as possible to the wider Australian community.
I'm just trying to, there you go.
So a little bit of a background of who we are. Hopefully you should have figured this out. So yes, we are the recently established governing body for allied health assistance, and our main goal is to support, promote, inform and advocate for AHAs across Australia. We do have our AHA certification scheme. That is the structures that we put in place specifically for our practicing membership types in order to show that we're doing all the heavy lifting to take the burden off businesses themselves in order to make sure that their AHAs are appropriately qualified and have access to appropriate training in order for them to continue to work in the workforce. And we work to benefit the users of other allied health services across Australia, across all sectors. So this is just a little simplified crux of some of the memberships that we offer. So obviously the main ones relating to what we're discussing today would be the practicing memberships for your members. Their benefits, of course, would include options, most important in order to opt out for our indemnity insurance policies, depending on course as to what they may or may not be covered for already. Those of you that are affiliated to a business, the simplest thing to do would be to review what your current organizational indemnity insurance is like to see whether your AHAs are actually covered under your current insurance based on the delegation model and where they actually deliver their services. Because there's a lot of the grey area that we've identified, especially within insurance, as to whether the AHAs are consistently covered or not. So we've made sure that we've included insurance policies as an option for our practicing members if they do so like that extra bit of cover for themselves. All of our practicing members also get access to our professional indemnity platform in order to be able to abide by their 20 hours of CPD.
Do you mind if I just comment on this one, Andy?
Yeah.
Look, I guess the significant thing here is what we've taken is, so we've used world's best practices for a self-regulated profession. We work with a lady called Anne-Louise Carlton, who was actively involved in setting up the AHPRA regulation, has done a review of world best practice in health practitioner regulation. The model that we have adopted is the same model used by all of the self-regulated professions in Australia: speech pathologists, social workers, dietitians. And the thing that is different for AHANA, if you're a speech pathologist or a social worker, your entry to that profession is through an accredited training program. So we know that everyone who is a member of that profession has completed that training. We don't have that for the allied health assistant workforce, and we don't have that for the disability support workforce or the aged care workforce. So what we've had to do is create a membership structure that allows anyone who is currently practicing as an allied health assistant to enter, but allow that to set standards within that entry framework. So they have to adhere to a code of conduct. I think these are on the next slide. Obviously have insurance, have a number of safety mechanisms in place. But what the tiered membership classes do is enable us to recognise high level of qualification. So our gold standard for an allied health assistant is someone with a Cert 4 in allied health assistant. So that is our practicing member certified. A practicing member general is someone with a Cert 3 and a certain amount of experience. And a practicing member provisional is anyone who is currently practicing as an allied health assistant, has the insurance, is doing some CPD and adheres to the code of conduct. The other point I'm going to make here is, and Andy was alluding to this, we know that at least 50% of allied health undergraduate students practice as allied health assistants, and it's a really important pathway for them. We want them to be practicing members because we know that if you're a first-year occupational therapy student, there's a pretty good chance you've never put your hands on anyone or actually had any training about interaction with a service user. So what our qualifications do is provide verification around what it means to be an allied health assistant. And just to give you an example, we've had people who are qualified allied health practitioners apply to be members of AHANA. If they don't have the Cert 4 in allied health assistants or equivalent, we don't automatically make them fully certified allied health assistants. So we're really trying to set up those structures and frameworks to recognise that there is a quality requirement to be a practicing allied health assistant. Oops, I think I've probably not got those certification requirements, but does anyone want to ask any questions about AHANA or what you've heard now? The other point that Andy made is that we do have mandatory ongoing continuing professional development, and we have a platform which provides free training. It's called AHACPD for those members, which has monthly webinars and weekly case studies and a discussion forum for participants. Okay, so just the last points. We know that there are a number of challenges to effectively employing the allied health assistants. Do you want to talk through these ones, Andy? I think we've probably covered a lot of them already. But
I think we have.
I guess if I can add to a couple of them. So we know that there's inefficient delegation. The third one, I think, is a really big issue in the disability support workforce. What we are seeing is a number of allied health assistants going out and getting their ABN and wanting to be employed autonomously to work as an allied health assistant. And then the allied health professionals are not employing them to do work with them because there is a confusion around clinical governance, supervision and employment. The allied health professionals believe, probably rightly, that if they're not directly employing the allied health assistant, then they won't be covered by their insurance. So we make sure that the allied health assistants have insurance. What they do get confused, though, is the clinical governance model, and it is perfectly possible to supervise someone if you're not employing them, and you can set that up through documentation, clinical documentation. So I think every week we have a question about that, don't we, Andy? People saying, I've set up my ABN, I'm self-employed, but people won't work with me because they don't think that it's safe to employ me. And we're really trying to get this message safe. Our insurer also supports that. One of the bizarre things is that allied health assistants have been excluded from the National Allied Health Strategy, which we don't really understand. But current training is still largely based on personal care rather than a model of rehabilitation and reablement, which doesn't fit well either with disability or the other allied health sectors that we're working with. Lack of access to necessary training models. Again, about weekly we get contacted by podiatrists who can't find foot care assistants or people with access to foot care courses. That's probably the biggest one, but we imagine that there are probably other gaps as well. And we've already talked about the articulation pathway. Is there anything you wanted to comment on that page, Andy?
Well, I'll just reinforce the thing about supervision and delegation more so than anything else, because of course it's already been discussed today, and then I've had discussions with health professionals earlier this week, and what I've seemed to find as to talking with allied health professionals is that the scope of an AHA is an ongoing evolution of the role itself, because the main identifying factor that we recognize more so than anything else is allied health professionals are always getting adaptations to their skills and their knowledge within their existing role. What the role and scope of an AHA is dependent on the tasks that the allied health professional can delegate to them. The main model that we've had described that seems to most effectively explain to an allied health professional how to safely and effectively delegate is they need to perform a clinical risk analysis. So reviewing all of their existing clinical tasks that they can perform in their profession, and then breaking it up into 3 sections. So low risk, moderate risk, and high risk tasks. So the goal, of course, would be to delegate the majority of your low risk and potentially moderate risk tasks safely to an allied health assistant, in order to free up the allied health professional to be able to focus on those more complex tasks that require more specific intervention by them. But then you need to be aware that due to the ever-changing landscape of healthcare, that risk analysis would need to be an ongoing process more so than anything else. I've been having fantastic discussions recently with psychology within mental health more so than anything else. And they're trying to do that same process at the moment and try and understand ways that they can more appropriately review their current clinical tasks and delegate more appropriately to an AHA if one is available. So the opportunities that we're trying to get out of this more so than anything else. So recognition for our certified allied health assistants, especially within NDIS and aged care. We submitted our co-regulation proposal to the Health Minister earlier this year. We're happy to discuss that a little bit more if required. We've submitted feedback all the way through the primary care safe practice review around supporting effective delegation for the allied health assistant workforce. And we're doing all we can to try and support career pathways through apprenticeship models and that sort of thing, and endorse competency-based training skills and support with some of our representatives from our association sitting on human ability. Thank you. Ah, wonderful.
So I think that's everything. So look, I guess the key takeaway messages are we have an established association. We have a framework for self-certification for the allied health assistant workforce, which we believe is transferable to disability support workers that are doing allied health tasks under the delegation or supervision of an allied health professional. It also gives the employers peace of mind because we've done the quality checking of that workforce. So there are about 8 pieces of data that we go through for allied health assistants to become members of AHANA, and they go onto a register and adhere to a code of conduct, and we have a complaints mechanism as well. So got a QR code if anyone wants more information. Are there any questions, comments, feedback? I've shared that report that I've placed on this. We're happy to share the slides with you, Chris, and everyone that's attended.
My other question is, I have 3 working for me at the moment, and they've started doing some shifts as disability support workers. Does AHANA, their insurance, still cover them if their work is more under that like disability support work rather than
The AHANA
work?
requirement is that they adhere to the AHANA code of conduct, and so I actually think all the work would be similar. The big risk is that they are working under the delegation or supervision of an allied health professional. But if they're working for you and you have delegated the work and they have clear competencies around that work, then I personally, this is not a legal view, would not see any risk to that. So it's the nature of the jobs and the fact that they can adhere to the code of conduct rather than who is employing them.
Yeah, that makes sense. And that's what I've been going off. And I think, especially they're all uni students at the moment studying different allied health degrees. A few of them I had through their school-based training on their placements, and then I've gone on to employ them afterwards. So I feel like as a business, that's been a great way of I haven't had to advertise because I know them, and then I've just employed them after their placement once they've finished their qualification, which I've been lucky to be able to do.
That's a great story to hear. Yeah. We need to hold you up as the pin-up girl for allied health employment.
And I've just felt that's worked really well for me. You get to know them, and it's a bit of a test run before you employ them and send them out working with your clients. But yeah, they've been great.
Megan, do you mind giving Matthew, Andrews and my email addresses, please? And I'll just
Molly, I think that's wonderful, and it'd be fabulous. I think maybe from the association's point of view to actually be highlighting, some champions of that sort of model. And particularly, where we're finding it's particularly difficult is in our, regional and remote areas. And growing your own is just such an important facet of actually providing those opportunities for careers. And so I think it would be fabulous to share some and to kind of break down the fear that so many small organisations have about taking on school-based or about taking on, the assistant workforce. Would be fabulous. I guess, Susan and Andrew, to the comments that were made a couple of slides ago, and one of them was around the training in disability in the disability sector has much more, and I will call it an assistant in nursing focus. The Cert 3 in individual support, which is the entry qualification, if you like, into the disability home care and aged care environment, is really currently not fit for purpose for either the disability or the home care environment. And with the focus and the growth in our home care support packages, I think the role for allied health assisting in that reablement and strengths-based, maintaining people in their home, I think the allied health assistant workforce is only going to become much more important. I think feedback to human ability around that sort of stuff, which I'm sure you're doing as a peak, but from all of us, and particularly I think from employers, is really, really critical. I know that the New South Wales Ministry of Health has actually put out a very good document around how to work with an allied health assistant workforce, which I think is is valuable. But how many people who are running their own businesses, Molly, have got time to sit down and read 45,000 pages of something that's sitting on a, website somewhere? I mean, hello, probably not. So it needs to be really practical. It needs to be short and sharp, and it needs to just address what it is. And that's where I think people like Molly and Chris, I'd love to hear your perspective as well, from the First Nations point of view, about bringing people into this role and being able to build them up slowly and kind of successfully into the allied health professional role, and being supported in community and being able to practice all of these things in community. I just think it's really critical, and I think there's such a gap there, but we really need to be doing it in, I don't know, it's how do you eat an elephant? Let's just take one bite at a time, and then all of a sudden we've achieved it. Do you know what I mean? And so I think we all need to be trying to work from what has been successful. And Molly, you're obviously a champion of that. So congratulations. And my goodness, I'd love to share your story.
Perhaps we could get a little case study of your journey, Molly, for AHANA. Would you? We'll follow up afterwards, and we won't put you on the spot right now.
Yeah, no worries.
Yeah, thank you. Matthew, you've got our email addresses. Chris, I know you came in late, and we're happy to share the slides. Are there any questions that? No problem. Is there anything that questions that you've got for us, or any issues that you'd like us to address?
Can you hear me?
Yeah.
Okay. So, firstly, I apologise for the late arrival. Indigenous Allied Health Australia is the peak national body the peak body for First Nations allied health disciplines in Australia. I totally agree with you, Susan. It's around growing our own, and we know in those thin markets in both disability and in aged care, in regional, remote and outer remote communities, there just aren't access to those professions. And one of the biggest obstacles in those locations, M5 to MM7, or however you want to classify them, is housing is one of the biggest issues. So AHANA runs 3 academies, one in the Northern Territory, one here in the ACT, and one in Northern New South Wales, where we offer a school-based traineeship for First Nations students. And they do 2 days a week. There's a training wage, and they're well supported by the AHANA Academy staff. And they do graduate with a Cert 3 in Allied Health Assistance. And throughout that pathway, there are multiple opportunities to do work experience, particularly with Aboriginal community-controlled health organisations. But we take them, we go anywhere. So a lot of the PHNs, etc., have been open to taking some of the students. And of course, allied health, the certificate in allied health assistance is just a starting point. And we would like to, and we have a mentoring program, and I run the leadership program in linking these young students with First Nations industry professionals in whatever discipline, and they are then taken through, and if they want to pursue a greater career in clinical roles or others, then we're here to support that. But it's about, as you said, Susan, growing our own, and in those markets where we simply can't get allied health services. So early days, but we're getting there. Over.
You've got some great models. I think they're the envy of all of us. Yeah. Great to see.
Thank you.
Thanks, Chris. Susan.
Sorry, I was just going to add there, and I'm not sure, Chris, whether you're aware of it or even AHANA, but my colleague in Western Australia, who sits in the same role that I do across all the community services and health area, has actually accredited a Certificate 2 qualification, which has both a working sort of Aboriginal health stream, but also an allied health assistant stream at that Cert 2 level, which has been incredibly successful as a school-based trainee, and particularly successful in regional and remote communities in WA. It's accredited, so it's fully recognised, the same as any qualification in the training package, but it isn't currently sitting in the training package. Now, they are in conversation with Human Ability, but, we know that's a slow process. But from a registered training organisation point of view, you can actually put that on your scope. And at that Cert 2 level, it's a really lovely introduction to wellness and well-being. It's really positive, as opposed to some of the quals that we've got in the training package, which has that kind of really high personal care focus, which can tend to scare some parents off letting their children do it from a school-based perspective, but also some young people who don't actually want to necessarily engage at that personal care level. It's a really positive, great qualification, and I'm very happy to kind of like link you into Caroline, or to, she's on holidays at the moment, lucky girl, but to have a look at it if you're interested, because it has got that allied health assisting stream, but it also has the Aboriginal health, so they can actually go then into the Aboriginal health practitioner pathway or into the allied health assisting pathway, which is really positive. So you might be interested in having a look at that as well.
We'd love to see that if you don't mind sharing it. Look, thank you so much for contributing today. We did say that we would make this recording available. We have all done a lot of talking. Are you happy for this to be shared on the AHANA website with your comments and things in it? We can edit those out if you prefer. All right, great. So lovely to meet you. Really appreciate your participation and hope to keep the conversation going. And thanks, Andy and Megan.
Thank you all.
All right. Thanks, Chris and Susan.
Okay. Thank you. Bye.
Bye.